Thank you, Dr. Alain. Good morning, everyone. I hope I'm audible enough and can be seen by everyone. To the team that has organized this Global Health Fair, which is the ninth of its kind, great thanks to you for the tireless work that you've put in to make this happen. My name is Arnold Paul Chibuka. I'm a medical doctor from Uganda, Kampala, which is the capital city. And I'm currently pursuing my master's in pediatrics and child health. I'm in my final year at Makerere University, which is the oldest university in the country. So I'm going to be sharing pediatric experiences here back home in Uganda, and maybe to give you a brief background. Uganda is located in Africa, in particular East Africa. We are at the equator and we are south of the Sahara. We are close to the Indian Ocean. Uganda is bordered by Kenya, Democratic Republic of Congo. It's bordered by Burundi, Rwanda, South Sudan, and on the other side you have Ethiopia and making part of the East African community. So I'm here to give an overview of what happens back home with regards to children. So in Uganda, we have had a population rise. We are currently sitting at about 45.9 million people. And of the 45.9 million people, it will interest you to know that actually 77% of that population is actually between the ages of 15 to 24 years. And as such, you will find that actually that population is under 25 years of age. And it will interest you to know that actually of that population, over 7.3 million people are between the ages of 15 to 24. And this means that the people who are aged between 18 to 30 years are constituting over 22.7% of that bracket. In Uganda, we have our main referral hospital, which is the national hospital, as Mulago Hospital, and that's where we do our clinical training from as students of Makerere University. And we have different regional referral hospitals in the different parts of the country. We have one in the north, which is Gulu Regional Referral Hospital, one in the southwest, which is Bara Regional Referral Hospital, along with Masaka Regional Referral Hospital, Fort Portal, and the like. And as such, it is these referral sites that work as the nets for much of the emergency referrals of all children. And all these referral hospitals are served by pediatricians, both at consultancy level and medical specialists at junior consultancy level. Over time, we've had an improvement in how we manage our children. I'll let you know that back then in the 90s, we used to lose quite a number of children. We used to lose about over 100 children back in the 90s. And right now, you'll see that our under 5 mortality rate has dropped greatly from 150 children to sitting at about 52 children right now per 1,000. And our infant mortality has dropped from about 90 children to about 36 children now. And the neonatal mortality has dropped from about 40 to now we are sitting at about 22 children per 1,000 live births. And of all these children who are dying, majority of them are dying from birth-related complications like birth asphyxia, prematurity. We are having quite a number dying from lower respiratory tract infections like pneumonia, and we also have a number dying from malaria. We are in the malaria endemic zone, and as such, we have a number of those who pass on due to due to malaria. We also have quite a number of children we are losing due to nutritional complications like severe acute malnutrition. And here, HIV accounts for about 1.4% of the deaths per 1,000 live births. So if we're talking about pediatric population in Uganda, there are things that we can't fail to talk about. One of them is where we stand at immunization of our children against the preventable immunizable diseases. We are grappling with rising cases of cancers in the pediatric population. We are grappling with nutritional challenges. Of course, we are also grappling with infectious diseases. We've talked about the things like pneumonia, malaria, HIV, and the like. And we are also getting an increased prevalence of children being diagnosed with congenital cardiac disease and other congenital anomalies. So when you look at our immunization journey back in the 90s, under the expanded program for immunization, we're vaccinating only 6 killer diseases, but right now we are sitting at about 11 to 12 killer diseases. And as such, you find that we've made tremendous strides in that direction, though we are still struggling with challenges like consistency, because some of these vaccines are having multiple doses. You find that there are children who fall out through the cracks because of inconsistency by their caretakers or parents to receive all the vaccines. We are struggling. Hello?
Yeah, you're back on. We can hear you.
Oh, thank you. We are struggling with the inconsistencies. Parents bring their children for immunization. Sometimes we tend to have stockouts of some vaccines. We also have areas like in the east where we have mountain ranges, Mountain Elgon. There are a lot of mudslides, so those are quite very hard to access for the vaccine teams. And all these things are creating hindrances in achieving elimination of some of these diseases. Though we have made tremendous strides with eliminating things like polio over time, and we are now seeing cases of polio because of our neighboring countries that are not fully immunizing their children. So we have transborder transmission of some of these diseases. And the other thing that we are really struggling with still is the mindset. We are still having people who believe that vaccinating their children is harmful to the children, that they're spying on the children, the vaccines are not safe. So those issues of vaccine hesitance are also challenges we are still struggling with. Maybe what I didn't hint about before talking about the pediatric challenges was how our healthcare system is set up. I happened to be in Edmonton late last year, and I noticed that in Edmonton they run more of a public healthcare system. In Uganda, we have a mixed healthcare system where we have public healthcare, we have private for-profit healthcare, and the private non-for-profit healthcare. So the public healthcare system is run by the government of Uganda, and this is what is responsible for funding many of the public health facilities, of course, in partnership with funding, with aid from the Western countries. And here you expect that when you bring your child, you should be able to get all services at no cost. And it's on a first come, first served basis. However, it also has challenges to do with stock out of equipment, stock out of consumables, drugs. Sometimes we've had health workers who have been constrained asking for money from some of these patients, and as such, people have come to think that even public health care, you have to spend some money to be able to access the services, which is quite unfortunate. Then we have the private for-profit, high-end healthcare facilities. Like top on notch, you have like my former workplace, which is now C-Care, running a number of hospitals, IHK, and the different satellite clinics around the country. We have Nakasero Hospital, we have Kampala Hospital, and these provide the state-of-the-art healthcare, but at a hefty cost, and they're normally served by they normally serve insurance patients and a few cash patients who can afford the charges. And then we also have the private non-for-profit facilities, and these are normally missionary hospitals, like where I did my internship from Uganda Matters Hospital, Rubaga, Zambia Hospital, and these basically patients have to pay to access the service, but they're paying a slightly subsidized cost to be able to access the healthcare services. So back to the second challenge away from the immunizable diseases, we are grappling with nutritional challenges. Uganda's nutritional state is marked by several challenges that impact health and well-being of its population. And one of these things is really malnutrition. We have a small segment of children who are struggling with overnutrition, but majority of them are undernourished. And we have over 33% of our children who are struggling with stunting, and about 4% of them are acutely malnourished. So you'll find that one of the where I work in Mulago, you find that we have a nutritional ward, and this is where we treat many of our children who are severely malnourished. And severe acute malnutrition normally stems from things like poverty, low levels of education, teenage pregnancies, giving birth to teenage mothers who lack the resources and social support system to look after these children. We have absent fathers, and as such, these issues are creating a lot of malnutrition in our country. Though that said, we are making tremendous strides towards solving some of these issues, and these numbers I'm presenting to you are actually a big step in the right direction, because they were way higher in the past. Also, not to mention under infectious diseases, back in the day we had issues with diarrheal diseases like rotavirus, but this we've been able to control with introduction of rotavirus vaccine in 2008, and right now the cases are very minimal, but we are still struggling with things like pneumonia despite vaccination. We are still struggling with things like measles despite still vaccination. We get those occasional outbreaks of these infections, and they really hit our children hard, more so those who miss out on the vaccines. But majority of them who are vaccinated are able to make complete recovery post-infection. And still under the infectious diseases, you'll find that we still have the HIV/AIDS scourge, which is really had an impact on our population. And right now, you will find that the prevalence of HIV in our population of children aged between 0 to 14 years is sitting at about 0.5%. This is a step in the right direction, because back in the day we were having these percentages at about 4%, but we've really tried hard through the presidential initiatives, mass mobilization and communication of HIV preventive messages, being more tolerant to patients with HIV and reducing the stigmatization, and also decentralizing HIV health care down to the lower levels of health care, and in addition to intense screening of all pregnant mothers as they're attending antenatal care to initiate them on ART before they get into the third trimester. All these steps have given us hope, and they have enabled us progress towards bringing down these infection rates among our pediatric population. All this has been possible because of the funding we get from the West. However, we expect that we shall get a bit of an increment in the numbers. Something we don't want, but is expected because the funding has been cut off. So we have to look at how to grapple with meager resources to be able to fund HIV treatment among our HIV population. Yes, the other thing I need to talk about are the cancers. We've had an increased prevalence and incidence of cancers among children. And this has been mostly because we are now able to diagnose them more and even be able to treat many of these cancers. We have set up Uganda Cancer Institute, which is next to Mulago Hospital, and also Mbara Regional Referral Hospital in the Southwest has a cancer treatment center. These have enabled us be able to effectively diagnose many of these children, and as such, we are having about roughly 750 children being diagnosed with cancer every year the biggest percentage is coming from is done from the Uganda Cancer Institute in Mulago, where we have about 600 children being diagnosed with cancer, and about the 150 coming from the Southwestern Mbar Regional Referral Hospital Cancer Treatment Center. So you find that we are diagnosing more of these cancers, and we are treating more children with cancers. Some of the commonest cancers we are having in Uganda, we have things like the leukemias, we have the lymphomas, we have the lymphomas, both Hodgkin's and non-Hodgkin's lymphoma. Then we have a bit of the Wilms tumor, and then the intracranial tumors. But also we are having children who come in with the extracranial tumors, things like osteosarcoma, rhabdomyosarcoma. We are getting them in and we are able to treat them, though their survival is still really low because they come in late, given the poor health-seeking behaviors of some of our children's guardians and parents. Yes, so the other thing I need to allude to is that currently we are, since Uganda is neighboring DRC and South Sudan, we are having a number of epidemics that we are dealing with in the country. We've had the measles epidemic, and here we've had continuous immunization of children with measles, but also we've had, towards the close of the year, even early this year, we had mpox, monkeypox, and just this week we had a grand round on monkeypox in a neonate who presented from just within the neighboring suburbs of Kampala. Luckily enough, the child was able to recover 100% and was discharged home with the mother. But we've had these outbreaks of mpox and measles. And right now, just last weekend, they declared that we had Ebola, the Sudan virus disease, which is the most contagious and virulent of the strains that was diagnosed one of our health workers in Mulago Hospital. So you find that this is coming in because of the poor health practices in the neighboring countries, more so DRC, where there is it's a war-torn country with a lot of refugees streaming into the country, and these are really putting a strain on our healthcare system, given that we've just come out of the COVID pandemic. So with this, they give you a simple snippet into where we stand as a country in regards to healthcare in the pediatric population. Thank you very much. Questions will be welcome.
Great. Thank you so much, Dr. Kibuka. Really nice overview of the challenges you meet and the types of cases you see and so on. So really nice overview. We do have time for questions and comments. I could be live here or in the chat or the Q&A. Anything from the participants in the room? Sorry for the technical problems. I think we're okay now.
I didn't realize I was sharing my screen still.
Oh, that's why. Okay.
But
That's
anyway,
okay. Arnold, I just had a quick question. You can hear me okay?
Yes, I can.
Perfect. Just with the oncology cases, it's got to be a challenge, and I think that's the reality everywhere, but certainly in the developing countries and so on, where a lot of the care will be done at the referral hospital, mostly or uniquely, really. So in Uganda, for any child in the country with a malignancy, with a cancer requiring treatment, it's all done at Mulago. You mentioned maybe a Southwestern referral center as well.
Yes, so Mulago at the Uganda Cancer Institute, that's our major, it's our major cancer institute, and that's where the major cancer wards are in the country, in addition to the one in the southwestern region of Mbar Hospital. However, as pediatrics, we have set up a network whereby using social media, also WhatsApp, in our pediatric groups, we are able to have our colleagues in the different regional referral hospitals and district hospitals being able to consult virtually the the oncologists in both Mulago and Mbarara to be able to come up with an early diagnosis and also possibly refer where they can diagnose or manage a suspected cancer.
Okay. And second part to that, do you still see lots of children either before the diagnosis is made or once it's made, but because of the logistical challenges of getting to Kampala, being treated with natural remedies in their home communities?
Unfortunately, yes. We are still getting some of this trickling in. We've had positive strides with the hematological malignancies because we have quite a number of hemato-oncologists. But other solid tumors, just last year there was a baby who presented with a possible osteosarcoma, but they were at a traditional healer's place, and all they were trying to do was to debride the wound and spray. And it was, I can share the photo if colleagues won't be offended by the photo, but by the time they came to us, the cancer had already metastasized, and the exit we could do, and actually we lost that baby. So yes, we are still having patients who still go to the traditional healers to get traditional remedies, and by then they come to us, the cancers are already metastasized to other regions.
Okay, thank you. There's a question from Dr. Houston in the room.
So this will work?
I think so.
Pick me up, okay.
Arnold, can you hear Dr. Houston?
Yes, I can.
Okay, thanks very much. A recent development has been the development of these two malaria vaccines. And I just wonder how things are going in terms of implementation and rollout, and which vaccine you're using, and whether you're able to assess a response.
Thank you very much. So in Uganda late last year, the information came out that we had the malaria vaccine done, and we incorporated it on our national schedule to be introduced this year. So the Ministry of Health announced this vaccine and it added it to the national schedule of immunizing our children. Unfortunately, I don't have the name of head for the particular type that we are using, but yes, we rolled it out this year and our children are starting to get the vaccine, though we have not yet been able to assess the response to this vaccine. But we are hoping that as we roll out the vaccine on the immunization schedule, we shall be able to pick up things like adverse drug reactions and response in regards to the number of children who are vaccinated coming in with malaria. Though it's also important to note that we've had an increase in the cases of malaria in the recent past, but we are hoping that with the vaccine coming in, it will help us reduce the levels. So yes, the vaccine has been added to our schedule, and we hope to assess the efficacy as we go along the journey. Thank you.
Thank you. Now there's a question, Arnold, from the chat with regards to the DRC, which, as you've mentioned, is facing so many challenges, both from an infectious disease point of view as well as a major conflict. Sherry asks, can you comment if the U.S. aid has stopped all their activities and other organizations in the Congo?
Honestly speaking, it is very hard for me to give an objective comment about that, but I can give you what is happening in Uganda. The information we have from Congo is coming over social media, but the last thing we had was that the different volunteers in the Congo had been taken out, and these were transported to both Kigali and Uganda by buses. But for our case, that I can positively confirm on is that all USAID projects that have been ongoing in the country have been halted, and all junior staff and intermediate management staff have been ordered to be away for a period of 90 days. They have only maintained the senior staff to, I think, close off a few things here and there. So for our country, that I can easily speak for, I can say the services have been halted from American-funded organizations. Yes.
Probably a double challenge in the DRC. The
Definitely.
Trump administration's orders, which potentially severe effects around the world, but as well the escalation and the conflict, right? So a very challenging situation. We have maybe time for one more question or comment.
Please.
I think there's a comment here for one of the attendees. The DRC is Africa's second largest and fourth most populous country, resting on approximately 24 trillion worth of natural resources. King Leopold concentrated on ivory and rubber in the range of his potential mineral wealth. Cobalt, the largest producer in the world. Copper, the largest producer in Africa. Niobium, tantalum, coltan, 80% of the world's reserves. Diamonds, 30%. Yet about a fifth of its population of about 100 million rely on aid to survive. Yeah, so a good comment there. A sad situation. Definitely. I just had a quick sort of comment / question, but Arnold, you mentioned the case of Ebola. I think I read that in the news. That was recent, and it was a healthcare worker, right, at Mulago or in Kampala. I assume that was quite stressful for the hospital, for the healthcare workers in terms of implementing protocols for potential infectious disease contacts and so on.
Yes, with regards to the Ebola outbreak, we were taken by surprise, and given that the first case was within Mulago Hospital by one of our health workers, a male nurse, it took us by surprise because by the time we made the diagnosis towards postmortem, so there were a number of contacts that were identified in the surveillance of what happened and where this gentleman would have passed, because this is a gentleman who fell ill on, I think, the 22nd of last month. He had a febrile illness, went to hospital. He had a duty to perform, and told his colleagues, I'm not feeling well. They took off a few samples, nothing significant, but they initiated him on anti-malarials. Sadly, because many of the people here think that every febrile illness is malaria, so they initiated anti-malarials. The next day, he wasn't still feeling so good, but he had to escort the wife to the immigration office to work on her passport. Then in the evening, he still had a duty in Mulago. He still came and performed this duty, and while performing the duty, that's when he collapsed. And efforts were made to resuscitate him, and he became a bit better. He was a bit stronger. He was able to go home. And but before getting home, he had to branch off to a healthcare facility in one of the Kampala suburbs, still rehydrated a bit and then sent home. The next day, went to a different facility, still rehydrated, called in the parents. He was taken to Mbale district. Mbale is his home area. That's in the east of the country, past Jinja. And while there, they say family doctor, still unable to diagnose the illness. Then they visited one of the traditional healers still. And then later on, they were referred to Mbale Regional Referral Hospital. In Mbale, that's when they felt maybe this could be Ebola, and they transferred the patient to Mulago. So by the time the patient got to Mulago on, I think, the 28th, samples were taken off, he was isolated, and on the 29th, he passed on. So the Ministry of Health officials have been able to canvass a number of these areas. Currently, the wife is unwell. The brother is also unwell, but all these are under isolation. Today I've been informed that even our even one of the children who was with the grandparents was also unwell. He was taken to Ginger Referral Hospital. They have also been able to canvass the area and isolate all the possible contacts. So the case took us by surprise, and it was in a health worker, and it meant that we also have health workers who have been exposed to the virus and they have been also isolated. So we are looking at it keenly and trying to take all the precautionary measures to see that we reduce the spread of this virus and also be able to offer supportive treatment to the people who have been suspected to have Ebola and also those who have been confirmed with Ebola. Yes. And maybe something that clicked my head, Professor Houston asked about the malaria vaccine that we are using. We are using the R21. That's the one we are using from India. Yes. We have already added to the immunization schedule, though we are going to be rolling it out officially in April this year. Thank you.
Okay. Yeah, thank you for the update on that case, and a very sad case. It sounds like a challenging one as well. So hopefully his family does okay, and any healthcare providers that were in close contact. So thank you again, Dr. Kibuka. A real pleasure having you today present, especially with the time difference. I know it's evening time there in Kampala, so we really appreciate it and looking forward to ongoing partnership between our centers. So thank you again.